So we have about 35, 40 minutes to talk. And what we're going to talk about are these 7 questions. So what is long QT? What are the causes of specifically long QT type 2? How is it diagnosed? Why do we do genetic testing? What are some lifestyle considerations? How do we treat it? And what are scientists doing to learn more so that we can push the boundaries of how to help patients just like you? So, to kind of go back to basics, long QT syndrome is defined as a clinical diagnosis where the QT interval, which is a measurement on an ECG, is prolonged, longer than most people would expect normally. Shown to your left here is a normal QT interval, and it's measured at the start of what's called the Q wave on the ECG towards the tail end of the T wave. And the space between that is time. And so more space means more time. Long QT syndrome is when that interval becomes more spaced out, becomes prolonged. And that essentially means the electricity of the heart takes a little bit longer to reset after the heart fires. So every heartbeat is started by electricity, and the electricity has to reset so that the heart can beat again. And that resetting is the QT interval. In patients with long QT, that time takes longer than other people. So that's essentially what long QT syndrome is. What are the causes of long QT? Well, you and I have about 3.2 billion letters, nucleotides that make up our genome. That's an amazing number, 3.2 billion. Every protein in our body we make because of this genome. And we have changes in this genome that occur between individuals. It's what makes us different people. And so genetic variation in this genome is normal and common. But sometimes genetic variation occurs in particular spots in the genome. And if they occur in spots that are needed to do certain things, that can cause human disease. And so long QT syndrome is when one of these genetic variants falls in an area of the genome that makes a particular kind of protein. For long QT2, it's a particular kind of potassium channel. And for the different types of long QT, it's different proteins. And all it takes is one misspelling in the right place, and it can disrupt that protein and cause disease. And so out of those 3.2 billion nucleotides shown here is one misspelling. You can see it here by a double peak below this blue arrow. And that's the mutation that caused disease in this patient. And it's a double peak because we all have 2 copies of the genome. And so not only is it a misspelling, it's a misspelling in only 1 copy. There are a lot of different types of long QT syndrome. We're here talking about long QT syndrome type 2, but there are a lot, about 17 different kinds, each one of them caused by one of those misspellings in a particular area of the genome called genes. These genes do different things in the heart, including causing ions, which we'll talk about, to move into the heart. And when you disrupt it, the ability of those ions to move is also perturbed. And that reduces or that prolongs the amount of time it takes for the heart to reset, causing long QT. For long QT syndrome type 2 specifically, it's a mutation in a gene called KCNH2. You can remember long QT type 2, KCNH2 as the genetic cause. This gene makes a protein, and that protein has lots of different names. Sometimes we call it HERG, H-E-R-G. Sometimes we call it KV11.1. But the gene is called KCNH2. And so if you're looking at your genetic test report, that's probably what you'll see. And just know that you're not alone. There's long QT syndrome type 1 all the way through long QT syndrome type 17. So if you end up having a webinar on all of these, you'll have your full slate of webinars filled for the rest of the year talking about all the different kinds of long QT syndrome. What are cardiac ion channels? So to understand what an ion channel is, you have to go way down into the cell itself and talk about the molecules of the cell. So if we take a heart, shown here is a healthy, normal human heart, we take a piece of it and we look at that piece under a microscope, we'll see something that looks like this panel in purple, where you see cardiac cells that make up that tissue. And if you blow that up even more, to the outside of that cell, a lipid membrane that surrounds all of our cells, there are ion channels that sit in that lipid membrane And the jobs of these is to allow salts to move from outside to inside or from inside to outside of this lipid wall. Think of it like a building where if you have no doors in that building, nothing can get in or out, that building is not going to be very useful. The doors have to be there and they have to be functioning for that building to be useful. Same thing for the cardiac cell. These ion channels are needed to make that electricity in the heart. Without them, things go wrong. So way back, 1995, gosh, that seems like forever ago. Last week seems like forever ago. But back in 1995, Mark Keating, who was really a pioneer in this field, wrote this paper. It was published in one of the top journals in the whole world called Cell. And he described for the first time a misspelling in the gene KCNH2, which makes hERG, as a cause of long QT syndrome. As you can see here, all the way to the right, this is how they used to do sequencing back in the day. Huge 3-foot, 4-foot, 5-foot gels that they would run. And somebody would literally look at all these different bands and say, what is different between wild type, normal, and this patient with long QT? And if you look very, very closely, you can see that one of these bands is different under this thing that says missense. And that was the single misspelling in the entire genome they were able to track down. And for 1995, this was absolutely groundbreaking. This was the cause of long QT syndrome type 2. And since this paper, we know a lot more about how these misspellings come to be. Change the cell and how it perturbs hearts and how to treat it. But this is an amazing discovery, especially for 1995. So what is long QT syndrome type 2? We talked about it being a mutation in a gene, KCNH2. That makes a protein, KV11.1. And this is a picture of what that protein looks like. Now, of course, these colors are here to kind of show different parts of it. But this is what that protein looks like. So if you zoom up really far, you can see the structure of this protein. And it's actually really quite beautiful. It's the perfect door for your cells. And it's got this top part here, which opens and closes. You can see these things that look like little candy canes that kind of all collect together. These candy canes open and close in a functional unit. And what they open for is a salt called potassium. And so when this thing opens, potassium goes across and that causes a current. If you think about, electricity moving along a wire, same principle. That current is really important because that current's what's needed to reset the electricity of your heart, along with a couple of other like currents. And we can use this to study how these mutations work. We can use it in the lab. Okay, but this is the basis of long QT syndrome. A misspelling in this ion channel leads to a problem with the current, leads to a problem with the heart resetting electrically. That's long QT syndrome type 2. Shown here is a picture of that current. So the y-axis here is the difference in electricity between the inside and the outside of your heart cell. And it's negative normally. And so for the heart to fire, it has to change that electricity and go up. And so when it fires, there's no problem, right? The heart can fire, no problem. Remember, the problem is with resetting. And so this current, this KV11.1, this potassium current is needed to reset the cell back down to that negative potential. If you don't have that, because there's a misspelling in the gene, makes a defective protein, then the time it takes for the heart to reset takes longer. And remember, the long QT is really just time. So what you're seeing here is the effect of that mutation on an ion channel that prolongs resetting, that leads to a QT prolongation that we can see on ECGs. And we can see this if we look very closely in the lab. So if you understand this, you're ready to be a pediatric cardiologist, a clinical electrophysiologist, because this is the basis behind long QT syndrome type 2. How is long QT syndrome diagnosed? Well, it's really hard to do these cell studies on everybody, right? We have to get a cell, we have to do experiments on it in the lab. What's much easier is a ECG. And so when you go see a clinical electrophysiologist, it's highly likely they're going to get an ECG. You've probably seen these before. This one has 12 leads on it. And what it does is it looks at the electricity moving in the heart, both the firing and the resetting. The firing is this big spike shown here. Now, if I move my mouse, can you all see the mouse?
Yes, we
Yeah,
can,
okay.
Andrew.
Okay, perfect. So this big spike is the heart firing, and then this kind of bumpy thing afterwards is the resetting, and that is the QT interval. And so what they'll do is they'll do this ECG, and we'll zoom in and use electronic calipers to precisely measure that time. Now, the best way to measure it is actually in a couple of leads. And it's been shown that two leads in particular, lead 2 and V5, for various reasons, are the most consistent. Sometimes you may have experienced where people sometimes don't always agree on a QT interval. And so there are certain things that are in place to make sure we're all kind of measuring it the same way. QT interval tends to be most accurate here. And if you zoom in a little bit, you'll see something like this. So here is that big spiky thing. That's the heart firing. And then the T wave is the heart resetting. And the time between that is the QT interval. So this is the Q here, and this is the T wave, that kind of bump right there. Now, the machine, when you print an ECG, when I do an ECG in clinic, the machine goes, oh, I can measure the QT interval for you. And it often does, and it prints out a little QT interval at the top of the report. Oftentimes, that's wrong, and here's why. That QT interval is being measured by the machine where it thinks this T wave ends. And if you kind of look at it, you go, oh, yeah, maybe it does. Maybe it does. And there, see, you have this T wave and this long tail. So I'm going to use that to measure the QT interval. Well, that would be an inaccurate measure. And if you let the machine do it every single time, you're going to end up with a lot of people who have abnormal QT intervals by the machine who actually don't have long QT syndrome. So one of the ways that we try to standardize this is to measure it a specific way. And that's to use what we call a tangent method, where we look at the T wave slope and we say, where's the steepest part of that slope? And we draw a line from that steep part of the slope through a baseline. And we say that is your QT interval. Okay. So you may have had an experience where somebody says, your QT is probably long. And then you saw somebody else, maybe an expert, who said, you know what, it's not as long as I think it is. And this could be one reason why, because there can be differences in how people measure this. And so this is one of the reasons why you want to be sure that you have somebody who's comfortable measuring a QT interval. Okay. What is the definition of a prolonged QT interval? So a QT interval from about 350 to 459 is considered normal. 460 to 479 is considered borderline. If you're 480, you're considered prolonged. Now, I think of this as a spectrum. So, something magical doesn't happen when you go from 459 to 460 in terms of cardiac changes. It's just you're kind of getting into a range where maybe that QT interval is longer than normal. Just like nothing magical happens when you go from 479 to 480, but we have these kind of arbitrary cutoffs to start thinking about these in different kinds of ways. All right. So of course, what we're worried about with long QT syndrome is that this delay in the way the heart resets causes electrical instability of the heart. And normally, for every beat of your heart, that doesn't come into play because you're in a normal sinus rhythm. So the heart is coordinated in its contraction. But of course, the longer the QT interval, the higher the risk of developing a misbeat of the heart because the heart electrically trips over itself. And so this is the arrhythmia that we really worry about with long QT syndrome. It's called torsade de pointe. And it literally means twisting of the points, which I think is a perfect description of what this looks like. It's like somebody has a strip of paper and sort of turns it and causes twisting in that piece of paper. And that's what this arrhythmia looks like. And this arrhythmia, this misbeat of the heart, can be life-threatening. It can also be picked up by symptoms like fainting during abnormal times. But if prolonged, it can be life-threatening. So this is the kind of rhythm that we worry about with long QT syndrome. So why do we do gene testing if we suspect long QT syndrome? It's because, as you all know, the majority of patients with long QT syndrome will have an identifiable gene. Now, it may be with long QT that you end up with a KCNQ1 mutation, long QT type 1, or like you all, KCNH2, or an SCN5A or one of the rare ones. It's important to keep in mind that the different genes have what we call different yields. There's a different chance that you may find a mutation in one of these genes if you have long QT. The biggest two by far are long QT1 and long QT2. 30 to 35% of patients who have a long QT on ECG will end up having a mutation in KCNQ1. 25 to 30% will end up having mutations in KCNH2 and be diagnosed with long QT type 2. 5 to 10% SCN5A, long QT type 3, and the rest are rare. Okay, this is what we mean by yield. So this is an example of a KCNH2 mutation. And this is a copy of the genetic test report that comes back to the physician like this. It says, result positive. Tells you the gene, KCNH2. It tells you the variant. And it tells you this is pathogenic. Okay? So that means that this gene has this misspelling, and this misspelling leads to an early stop of the protein, which is predicted to cause an abnormal protein. And this genetic testing company says we have enough evidence that we think, depending on the case you sent us, depending on the literature, depending on what we see in healthy individuals, that this mutation is indeed causative of disease. And it's very important we get this right. It's very important we get this right for reasons we'll talk about. The genetic testing company does their best job in giving us, the physician, their best read. But remember, the physician who you all are seeing has always more information than the genetic testing company, right? The gene testing company, all they know is, I think this patient has long QT syndrome. But you've had a half hour, 45-minute visit with the physician who has a lot more information about you. And it's so important that we get this right that if I can leave you with just a couple of things, one of them would be make sure that whoever's interpreting that gene test has confirmed that they think this mutation is also pathogenic. And we'll get into why in just a second. If we are reasonably certain that a mutation is the cause of long QT syndrome in one person in the family, that has implications for treatment and for risk, like we'll talk about. But the big thing is that we can then try to use that variant, which we think causes disease, to find other people in the family who might be affected. And this is one of the major reasons why we do gene testing. So for example, this little girl here, maybe she came with long QT syndrome. She was clinically diagnosed. She got the gene test. She got a variant in KCNH2. She might give us a clue to identify people in the family who are at risk of having disease. And so once that first person is identified with a pathogenic variant, we'll do what's called cascade testing. And we'll start with first-degree relatives. So if it's a child, biological parents, siblings, half-siblings. If it's a mom and dad, children, siblings of the parent, grandparents. Okay? First-degree relatives, one step away from you. And in doing so, we can go, oh gosh, maybe dad's got the mutation here, and her other sister has the mutation, but her big sister and her mom don't have the mutation. So what does this mean? Well, because we are reasonably certain that this mutation causes disease, we're reasonably certain that the older sister and the mom who don't have the mutation are not at risk of getting long QT syndrome. Okay? That's a big deal. We're also reasonably certain that the dad and the other sister who are positive for this variant are at risk. It doesn't mean they're going to get disease, but it means they're at risk and should be monitored. Okay? Well, with a positive gene test, you can also get a negative gene test. About 1 in 4 patients who have long QT will get this result back. We don't know what your mutation is. It doesn't mean you don't have long QT syndrome, because remember, that's based on an ECG. This means we just don't know the genetic cause. And so on the research side, this is where labs like our lab try to figure out, well, what caused it then, right? Especially in families where something is being inherited, can we figure this out? So that's on the research side. On the clinical side, this means we don't know what what we call the biomarker, the risk allele is. There can also be this situation where we don't know there's something there. We don't know if it's disease causing. We don't know if it's negative. This is called a variant of uncertain significance. You may have had an experience with this. Sometimes we call it a VUS for short, because variant of uncertain significance takes a long time to say. And it says, well, you got this mutation, right? This happens to be in long QT syndrome type 1, KCNQ1. You got this mutation. We don't know enough about it. We don't know enough about it to say whether it's something we should ignore or something that we should be worried about in your family. So we're going to label as uncertain. Now, this has certain connotations to it, right? Remember, we only do cascade screening when we know what the mutation is. We shouldn't be doing cascade screening when we don't know. However, if you're in a place that has a good multidisciplinary team, we may actually do what's called VUS resolution testing, where we say, you're right, we don't know, but we know a lot more about the family. So let's try to figure this out by looking at other members of the family. And we'll talk very briefly about this. But know that if you're in this uncertain place, that we should not be making clinical decisions based purely on this without a whole lot of thought behind it, because we're uncertain. So this is an example from the Wall Street Journal a few months back about a different genetic disease. This family was diagnosed with a mutation, a misspelling in a gene called BRCA1. You may have heard about this one because it's the cause of breast cancer in both men and women, and ovarian cancer as well. And some mutations are labeled as quite severe, putting women at risk, very high risk, of having very bad breast cancer. And this family got the unfortunate news that their family has one of these mutations. So a number of women in the family underwent prophylactic bilateral mastectomies, which means they had breast tissue removed before any evidence of cancer came into play to kind of decrease this risk. You can imagine then their surprise later when they found out that actually we're not entirely sure that this variant causes the disease that we think it does, is the risk factor we thought it was. So this is just to illustrate that the field of genetics is rapidly changing. We're benefiting from it because we can diagnose patients we couldn't diagnose a few years back, but this field constantly moves and shifts. And so if I can leave you with a second point, it's going to be that when you're seen and your genetic test is interpreted, make sure it's part of a big team that understands genetics, that talks about a plan for continuing to follow you and your mutation, especially if something is uncertain. We always have to give ourselves a little credence to say this field is evolving, and we may or may not be as certain as we think we are. How is long QT syndrome passed in the family? It's what's called autosomal dominant in its inheritance. So if you remember Gregor Mendel and those pea plants, when he was working on that, he discovered lots of different ways that traits could be passed, and this is one of them. Remember, we have 2 copies of the genome. So if one of those copies carries the mutation, you can pass one of those copies to each of your biological children. So if you have an affected parent, there's a 50-50 shot. You could pass that mutation on to any biological child, 50-50. It may not, and it's independent of whether that child's a boy or a girl. It doesn't mean that you're gonna, pass it on to exactly 2 out of 4 children, or something like that. Like we're showing here for illustration purposes. It's like flipping a coin. Sometimes you can get heads 5 times in a row. Sometimes you get tails, but it means kind of overall it's a 50-50 shot. And if somebody inherits that mutation, they then have a 50-50 shot of passing it on to any of their biological children. That's an important thing to kind of keep in mind. But again, having a mutation does not necessarily mean you're going to get disease. That's a concept we refer to as penetrance. So diseases that have we call incomplete penetrance, all that means is you can get the mutation, but that mutation may never manifest as QT prolongation. You may never be diagnosed with long QT syndrome, and that has implications going forward. We talked about sometimes, well, gosh, maybe, if we have these VUS resolution testing, what does all that mean? Well, sometimes if we have, particularly in my clinic, we have one child who's affected quite severely, potentially. And we kind of don't really know if this variant is the reason for their disease. Maybe it's called a VUS. One of the ways we can kind of get more information is to test the parents. Because if we know the parents are stone cold normal, there's no family history, and the other kids are normal on evaluation, and everybody else is negative except for the one child, it actually shifts our probabilistic thinking into thinking, well, maybe this variant's not really a VUS after all. And that has implications for the family. This is called de novo inheritance. Oftentimes, we see this in kids who present very early with disease because they're the first ones to get it, right? If it was being passed from generation to generation to generation, it would have been caught a lot sooner. All right, so you've got this diagnosis. We've done a gene test. We've shared the results. What do we do about this? And you know, I really believe that this is a team effort. So you're coming in with your individual values, your individual worries, your experiences, which we're just getting to learn in clinic. We're coming at it as the physician or the practitioner with a bunch of knowledge about risk and what this means for you. But our job is to work as a team to make sure that your worries, your goals match up with our worries, our goals. And so this is really a team effort. And so, it's really important to have conversations, ask questions, get more information when you face these diagnoses. So the first thing we always talk about are easy peasy lifestyle modifications, right? First one, long QT syndrome type 2, stay hydrated. All right. We talked about how the salts in the blood are needed to make sure the heart resets. And so typically not a problem, but say you get a little dehydrated, you're out running in the heat, maybe you get a stomach bug and you start throwing up, COVID, right? All of a sudden you start getting dehydrated, the salts in your blood start changing, and that can be a risk factor. So we tell all of our patients, stay hydrated. Fluids are your friends. I like this sort of Gatorade Zero, the G0, because it's got no sugar, especially for the kids where it's helpful, but it's got all the salts that you need to make hydration efficient. There's lots of things too. You can try Pedialyte if you have a little one. Adults can drink Pedialyte. I've tried it. It's not the greatest, maybe, but if you like it, it's also that's also an option. Powerade as well. Something to keep you hydrated. If you like water, then water with some sort of a salty snack is helpful because that salt makes the water go into your system better. So stay hydrated. This is where knowing the mutation actually helps. So people like Mike Ackerman have spent a lot of time figuring out what are the risk factors, the triggers for sending someone from a normal sinus rhythm into one of those bad rhythms like torsade de pointe. For long QT type 2, it's what we call auditory or hearing stimulation. So loud doorbells, alarm clocks, cell phones, pagers. This is a big one in my field. My pager goes off and it is loud. It's scary. That kind of startle from a loud noise is a known trigger for long QT syndrome type 2. So the best thing you can do to kind of mitigate that, get one of those alarm clocks that is like plays really gentle music, starts off really soft and then builds. So it's not like a really abrupt awakening in the morning. Vibratory ringtones that are gentle and easy that don't kind of surprise you all the time. Those are things to consider. Avoidance of long QT or avoidance of QT prolonging drugs. So many medications that we prescribe for other things, whether they're antibiotics, mental health medications, these medications can sometimes block potassium channels and prolong QT. And for most individuals, it's not really a problem, which is why we don't normally think about it. We provide somebody with a prescription for azithromycin. But for you all, with a KCNH2 mutation, you should be mindful of this because adding a medication that prolongs the QT on top of having long QT syndrome could increase your risk of having an arrhythmia. So, I've been in situations where families like, I had to go to urgent care, right? It was a Sunday morning, and they looked at me like I had two heads when I said, hey, does this prolong the QT interval? And so this is a website that you can kind of carry with you, have on your phone, qtdrugs.org. It's a website by Credible Meds. And this is what I use in clinic. And so if you have this website and maybe you're in urgent care with your little one and you're worried about QT prolonging medications, you can type that medication into this website and be the advocate that you need for your family, even if the other providers don't really kind of know, how to interface with this. And so This is a great resource and freely accessible, and I recommend that you use it. Sports participation always seems to come up, especially with teenagers in my clinic. And this is an area that's rapidly changing and shifting. And so you may have some providers that think very differently than other providers. And that's just a sign that kind of we all think a little bit differently. This is the way I think about it, and I would love to get your thoughts in the Q&A. So I think of this as risk, not as a cut and dry sort of a thing, but remember as risk. And part of my job is to talk with you about what your goals are, what you're hoping to get out of sports participation or your teenager, and then see how we can match these up. And this is something called shared decision making, where I'm not making a decision unilaterally, you're not making a decision unilaterally, we're talking about it and sharing our perspectives. The way I think about it is there's a gradation of risk, where some individuals who have maybe that KCNH2 mutation, but they're not penetrant, their QTs are stone cold normal, they've never had any symptoms, those people are pretty low risk. And generally, most practitioners would say they can go and play sports, no problem. If you have the long QT mutation and you have evidence of long QT on ECG, but you're asymptomatic, that probably means your risk of having an event slightly higher. It goes up if you're symptomatic. By symptomatic, what really frightens me is unexplained fainting. The stuff where, like, I was walking and I woke up on the ground. Like, that is symptomatic. That would be something that we'd be worried about the heart. And then the highest risk would be patients with really bad QT prolongation who have symptoms. And so there's risk, right? And right now, if you look at guidelines that we use to treat patients, it would say that, if you have low risk, you're probably fine to play. If you have high risk, you really have to have a conversation about risk and sports participation that takes advantage of shared decision making. Regardless, I always think having a plan is important. So one of the things that we really talk about is what would happen if your child athlete has an event while practicing, while playing in a game, while at a track meet. Is there an AED? Who knows how to use it? How close is it, right? What's going to happen? Talk about it with your team. Talk about it with your family. Talk about it with the physician. That's shared decision making and having a plan. That plan is critically important. Okay. Medications. Typically, beta blockers for long QT syndrome type 2 are the frontline therapy, which means it's the first medicine that we give. Nadolol is the gold standard medication, particularly for patients who are old enough to be able to swallow pills. And it has a nice benefit of being either once and sometimes twice a day, but potentially once a day, depending on how people tolerate it. If babies are too little to swallow pills, then propranolol is what we use. That has a downside, depending on age, is 3 to 4 times per day, which can be kind of a pain, but is a great medicine for long QT syndrome type 2. When we start children, or particularly babies, on beta blockers, we can start them on kind of full dose beta blockers, no problem. Most kids will never even know they're on a beta blocker. Sometimes with adults, they can kind of feel it a bit more in terms of that fatigue than in younger children. And so we'll start lower and go up slow. For individuals who have had a potentially life-threatening arrhythmia, or ones who are at very high risk of having one, maybe if they've had those fainting episodes that we get worried about, ICDs kind of come into play. In adults or children of over about 25, 30 kilograms, you can start to do what's on the right here, which is a transvenous, minimally invasive ICD, where the shock box and its computer go under the skin, and then the leads go through the major veins that go back into the heart. And then in very young babies who are too small for something like this needs to be surgically implanted. And that's an open chest, not an open heart, but an open chest procedure with our cardiovascular surgeons. And so this obviously carries a lot more sort of risk with it, and the procedure is a lot bigger. And so we reserve this only for our sickest children, our sickest infants. People like Mike Ackerman have really pioneered the use of cardiac sympathetic denervation for individuals who may not be tolerating beta blockers, or there's lots of ICD shocks, as an augmenting way to reduce risk in certain patients. And this basically involves taking out this chain of neurons that we think sort of predisposes the heart to having arrhythmias. And by taking it out, that risk is reduced. And these are for selected patients in the right circumstance. And certain centers do this a lot more than other centers. But what about prevention? So I think prevention is something that's important, not only for patients with long QT syndrome type 2, but for all channelopathies. And so I'm a big advocate for public AED use and public AED education. There is this wonderful project called Project Adam, which was actually started by a family who lost their child, Adam, during sports and was unable to be resuscitated because they didn't have an AED around. And so we actually, as we have a North Carolina affiliate of this, and many states do. You can see if your state does too. We actually go to public schools and we help them drill for what would happen if you had a child go down. We help them find and get an AED. We help them use it, right? And we help them to make sure they have all their questions answered. I'm very proud the first state or the first school in North Carolina was Hillsborough Elementary School, which is the elementary school my kids go to where my wife works. And so maybe a little bit biased, but they are Project Adam certified. And so that's a great resource for families. And finally, in our last two slides, just two things about what's science about right now. Right? We know a lot about how long QT syndrome type 2 happens. What are we doing to kind of push the boundaries? Well, this is one way. So this is really born out of our need to learn more, particularly about kids who don't have a genetic mutation, right? Where we don't know what's wrong with their hearts. Maybe they have long QT, maybe they had an arrest like this unfortunate child did. How can we learn about their hearts when we don't know what the genetics are? And this is one way. It's induced pluripotent stem cells. You may have heard of this. We can take a simple blood draw. We can do this from an infant who weighs 3-4 pounds all the way up to somebody who's 101 years old. And we can convert those blood cells into those patients' stem cells, which is really, really cool. These stem cells are shown here. These are just like the stem cells inside of that child when they were an embryo. And these stem cells want to do different things. They want to become different kinds of cells. And if you give them the right signals in the lab, they can become this. These are beating heart cells. We can make all kinds of different cells depending on what we think is wrong with the child. We can't do this for everybody, but for the ones where you really think there's an opportunity to learn more and the families are willing, we study these in the lab, and it's really been a powerful tool because we can not only learn more about disease, but we can try novel therapies. And we talked about a couple of these. If you were on the SAD live Facebook yesterday with Mike Ackerman, we talked about lumacaftor, which is a cystic fibrosis medication being tried in cells like these to see if KCNH2 loss of function trafficking mutations could be rescued. So these are an invaluable model for both discovery and potentially for novel therapies. And then finally, studies like this. So what you're looking at is what's called a Manhattan plot, which I love the name because when I think of the Manhattan skyline, I think of really tall buildings, and all these dots at the bottom are kind of like Manhattan skyscrapers, I think. All these dots are areas of the genome which are associated with patients with long QT syndrome. And there's been a number of these studies that have been done. And we're starting to realize that certain mutations, these are not the rare ones, the ones that land, like we talked about, just in KCNH2, but these are common ones, common genetic variation that make us just different people, may, in the right circumstance, add together a little effect here, a little effect there, and in the right circumstance, cause long QT syndrome. Or if you have a gene like a KCNH2 mutation, can make it so that either that mutation doesn't manifest in disease, is non-penetrant, or makes somebody really quite sick. And so studies like this involving the entire genome have the promise of being able to explain some of the variation we see in families. But again, these studies are in the beginning stages, and we have a long time before we can predict, based on these studies, differences in drug response and in events and severity. But this is kind of where the field's going. And I'm very excited about this. The next couple of decades are going to be very exciting. So this is my team. We all have people that make us better. These are the smart people I get to work with every day. They do all the hard work. The picture to the left is pre-COVID, of course. Now, picture to the right is how we do our lab meetings. And it's a great place and it's a great team. We have basic scientists, people who study molecules and cells, all the way up to people who are training to be pediatric electrophysiologists. Um, and that really creates a really unique environment for us to make discoveries. Down there at the bottom is my contact information if you ever want to chat. And these are my funders. And with that, I will thank you for your attention and will welcome any questions.
Thank you very much, Dr. Landstrom. We have some questions coming in the chat, and we'll just start from the top and go through them. Sandy asks, if someone has an ICD, do you suggest that they also have an AED at home?
That's a good question. So I think it depends. I typically ask most families with long QT syndrome, even if some have ICDs, to have an AED available, typically, but sometimes they can be expensive. So it's kind of a balance there. I think if it gets to be very expensive, they can't afford the cost, or having it in multiple places, like having one, say, at school and at home and at work, gets to be too much. It's a balance. So it really depends. And, also some patients are really quite well managed when they have an ICD. Maybe they're on a good dose of beta blocker and that ICD is almost never used, right? They never get a shock. And so if they never get a shock, and that's good, right? They're well managed on the beta blocker. Whether you have to have a separate AED, you can go either way.
Okay, thank you.
Mm-hmm.
Carl asks, what is the current understanding of genotype-phenotype correlation? Type 1 is associated with exercise, type 2, loud noise, abrupt awakening, yet both are due to similar ion channels in the heart.
Yeah. So you should come work in my lab, because that is a huge question that I'm not quite sure we fully understand. There's some thoughts that, for example, the auditory trigger kind of makes the adrenaline surge for just a minute. And that adrenaline surge may actually trip up this particular channel into causing disease, to causing those misbeats. But I'm not sure if all those details are known. It is well described that certain phenotypes lead to certain, or certain genotypes lead to certain phenotypes. But I'm not quite sure if everybody knows what those true mechanisms are, because but it's really an exciting thing to look at, because potentially we would learn a lot more about the disease if we knew all those mechanisms.
Okay, thank you. Anne asks, is it true that a change in hormones during pre-puberty or puberty can increase the chances of an episode occurring?
Yes, in particular for long QT syndrome. So in particular for females. So we know that one of the things that can change somebody's risk is estrogen. So estrogen, like a lot of those long QT syndrome prolonging, or long QT prolonging medications, the estrogen can slow down the potassium channel. So we see a fair number of little ones who, before they hit puberty, their QTs are normal, and then they start to go through puberty, and that estrogen level goes up, and we see they really prolong then. So the QT that we see on the ECG from you is really a summation, an additive effect of genetics, of hormones, of medications, of the salts in your blood that specific day. And so modulating any one of those can make that QT prolong or even recover a little bit.
Okay, thank you.
You're welcome.
Catherine asks, what are your thoughts on patients with long QT getting early access to the COVID vaccine?
So, the COVID vaccine is one of those sort of resources right now that unfortunately we just don't have enough shots to go around, and hopefully that'll change. Do patients with long QT syndrome sort of meet the criteria of being a vulnerable population? I'm not quite sure if that's necessarily the case. Mm-hmm. And so, I think everyone should get their vaccine, absolutely, as soon as they can. But whether long QT syndrome in and of itself is a predisposing factor, I'm not sure if that's the case.
Mm-hmm. Okay, Orto Andy from Hungary, I believe. Are the drugs on the credible meds still safe, on the credible meds list, still safe if we combine them with beta blockers? And how about taking Nadolol during pregnancy and breastfeeding?
Yes. So, just because a medication is on credible meds as potentially prolonging the QT interval doesn't mean you can't use it in the right circumstance. And so what we talk a lot about with families is if it's a life-threatening event, right? And that medication needs to be used, use it, right? All of this is probabilistic. There are kids in the hospital with long QT syndrome or long QT for any other reason who we need to start these medications on for a variety of reasons. We try our best not to. Is there an alternative we can use? Can we change the dosing? But in certain situations, it's simply not possible. And so all that means is they're at increased risk. And we need to balance that risk with what we're trying to treat in the first place. So if it's something small that doesn't have a whole lot of risk, but you're giving this medication on top of it that increases the long QT risk more, maybe it's not needed. Versus if it's something that, we're going to be in a hospital, we're going to be well monitored, we're going to be able to watch your heart very carefully. And what we're treating with these is really important. Say cancer, and the only anti-nausea medication they want that works for them is Zofran, then that's a different conversation. So it's all about risk and what you're trying to do with the medicine. It's not a hard stop.
Okay. Carla asks, can the fainting episodes linked to long QT syndrome ever present like a seizure? Also, if someone faints because of long QT, does that mean they have torsades?
It's a great question. Both of those are superb. The first one, whether there is a link between seizures and potassium channel mutations, the answer is yes. So it goes both ways. So patients with long QT syndrome type 2 have a higher chance of having real seizures. It's not everybody, it's a small proportion, but it's higher than the general population. And it has to do with the way that these ion channels are expressed in both the heart and the brain. So you can have real seizures. Then you can have seizures that are not really seizures. They are sort of seizures that look like seizures, but they're really this arrhythmia. And the signs that you see of the patient are actually just this arrhythmia. And so those seizures require more investigation. We want to figure out, is it the heart or is it the brain? All right. And to the second point, this was about fainting. You can certainly faint with long QT syndrome and not have torsades. The classic scenario in my mind, I follow a couple of adolescent females, teenage girls who they stand up and they feel like they're going to faint all the time. I kind of feel like that sometimes too, especially if I'm dehydrated. And so it's really hard to make sure that we're figuring these out precisely, because you don't want to say, well, you fainted once and jump to throw in an ICD, especially in certain populations if it's not needed. And so oftentimes we'll do our due diligence. We'll place event monitors. Sometimes those event monitors go under the skin so we can wear them for months to see, are you showing any signs of bad arrhythmias like torsades? And let me know, if you ever faint. And we had one who we placed one of these event monitors and she fainted and it was normal heart rhythm. And so I'm glad that we didn't jump and put an ICD in her right away, because it's likely it was just normal teenager fainting. At the same time, can she still have a torsade event? Absolutely. But in that particular instance, it was good that we were able to catch the rhythm to show that it was not torsades.
Thank you.
I think you skipped one of toes.
I'm sorry. Go.
Taking Nadolol during pregnancy and breastfeeding. Is that okay?
So I will say I am not the expert on Nadolol during pregnancy. My training is focused on pediatrics, and so I will say there are people who can probably give you advice on that better than I in this particular instance.
Okay. Iris says, what other pathways auditory triggers? I'm not sure I totally understand. Iris, can you clarify a little more? Let me ask the next one here. Rob, what potential adverse effects may result from taking metoprolol long term?
Metoprolol?
Mhm.
So yeah, we didn't talk much about metoprolol. There are, of course, other beta blockers that are out there, metoprolol being one, atenolol being another. Um, you know, we see a variety of different beta blockers that are used. There have been some studies that suggest that natalol, what we call non-selective beta blockers, have a bit more ability to quiet the heart and prevent misbeats like torsades than beta blockers like metoprolol. So, in those situations, typically, if I'm seeing a patient who's on metoprolol, I will, try to convert them over to natalol because of that increased what we call efficacy, the ability of the medication to work well for that disease. And so, it's not that metoprolol has any worsening side effects; it may just not be as effective as natalol. And sometimes patients, kind of going along this, patients will ask if we're having to start a baby on a beta blocker very early, or maybe a toddler. What's the developmental impact of starting these beta blockers early? The answer is zero. There is none. Sometimes in small babies, we get worried a little bit about low blood sugar. And so typically, if we get worried about that, we'll just check their blood sugar as we're starting the medicine. But really, there is no developmental impact or anything like that on pediatric or earlier beta blocker use.
Okay, thank you. Carl Barnes is a primary care internist. He asks, how does your team that has been working with a child's pediatrician approach the timing of transitioning to adult care and supporting educating the new PCP?
So something that is really important is working with the PCP at all ages. So whether it's a pediatric patient or a patient in that transition point or an adult PCP, it's really important. Um, you know, Especially when they're growing, like in babies, weight doubles. It seems like every couple of months, you're having to work. You can't see them all that quickly, and so you're partnering with the local pediatrician to make sure that we're getting weights and we're weight adjusting, say, propranolol. In terms of age, it's really up to the patient. It's up to the family. And so personally, once patients get above about 30 or so, my training is mainly pediatric, and there are people who are much smarter than I am who can treat disease and handle kind of all the other stuff that comes with being 30 years old or over. And so that's sort of my rough cutoff. However, if patients are going to college and they're going to college out of state and they want to see somebody locally, which is perfectly acceptable because just in case something happens. And they say, well, maybe I'll be out there for 4 years. Maybe I'll do grad school. Maybe I'll do these other things. And they want to stay out there. That can dictate when you do the transition point too. Either way, the onus is on us to work well with the local PCP to be able to make sure that transition happens in a way that facilitates the care of the patient, makes the PCP comfortable, and works in favor of the family. And so all of these things kind of come into play. But generally, kind of end of college-ish, up through about 30 is when I'm thinking about doing this.
Okay. Emily asks, are there any considerations to take into account with long QT while pregnant or after giving birth?
Yeah. So with long QT in general, pregnancy can bring out arrhythmias, especially in the period after birth. That's a period of time where there is more vulnerability to arrhythmias, and so it's something that as you're going through pregnancy, to keep bringing this point up and talking about it with the obstetrician to make sure there's a plan in place to make sure that you're safe throughout this period of time, because yes, the risk is there.
Okay. Could you please share some main points to include on a 504 plan for a child with long QT type 2 entering kindergarten, in addition to advance notice of fire drills and training in the teachers to recognize SCA and using an AED?
Yeah, this is a phenomenal point. So really, it involves oftentimes picking up the phone and talking directly to the teacher. These kinds of sort of ways of how best to treat kids with medical conditions are critically important, not just for fire drills, but for, if you're worried about fire drills and your child's got true long QT syndrome, there needs to be a plan in place for what if something happens? What if he or she faints, right? What if he or she can't take their medicine in the afternoon for whatever reason? What happens in that situation? And so typically what we do is we get a sense from the family about the school. Parents are really good. They know their teacher, they know about the school, they know kind of where they feel comfortable and where maybe areas that they feel less comfortable are. And then we try to tackle that. And if it's in the form of a letter, we try to be very specific. Should avoid, surprise fire drills, for example. Should always take this medication. If not, to give us a call. Be very specific. And we can oftentimes provide that letter, and sometimes that's enough. Sometimes it is not, and we just literally pick up the phone and we call the school nurse, or we call the teacher and talk about it. And that's really the best way.
And I might add that the SADS Foundation also has individualized care plans that you can share with your school nurse and teachers for your child. So you can check SADS, stopsads.org. Our website has those individual care plans.
And they are phenomenal, and I use them. So they are phenomenal.
Excellent.
Perfect. And Michelle actually did add that. So thanks, Michelle.
Yeah.
She says she already has one for her kids.
Good. Okay. Scott asks, when would you implant a device on a girl child considering pre-puberty, even if they're on a beta blocker? When would you?
I presume that we're talking about an ICD in this situation.
Mm-hmm.
So ICD implantation, like I said, in this age group, is really something that you want to do judiciously. There's a lot of growth that happens in puberty, and that has considerations because the ICD sometimes doesn't grow with the patient. And so, implanting at the beginning, knowing that they're going to grow, is an important consideration. There's lots of sort of guidelines that we use for when ICDs are even considered. The first is, how's the beta blocker going, right? So if you're a teenager on Nadolol, you're on a good dose of Nadolol, and things are great, asymptomatic, and even if the QT is long, without any evidence that you're having symptoms or cardiac arrhythmias, I would really drag my feet when it comes to implanting an ICD. If you're concerned, well, gosh, they're looking okay now, but gosh, what's going to happen at the high estrogen levels for adolescents, which is what I think you're asking about. I say, look, let's see. We know that patients with KCNQ1 mutations and KCNH2 mutations should respond really quite well to beta blockers. So if you're on a good beta blocker dose and that QT prolongs a little bit with adolescents, but the patient remains asymptomatic, has never fainted, and there's no concerns for arrhythmias and things like that, I think you're fine holding off on the ICD.
Let's see. Emily asks, how early do you recommend testing children that are born to a parent that has prolonged QT?
Yeah, this is an important point. So you can go many different ways, and this is where that shared decision making comes into play. So there's some people, and this is mainly born out of diseases that present later in life. So if, for example, we thought that long QT didn't present until they were an adult, some people would say, well, gosh, you should wait until that child grows up. That child can then decide for themselves whether they want to know if they have the mutation or not. Long QT syndrome, as you all know, can present a good bit earlier than that. And you can have babies and children who are affected. And so typically in that situation, we say, well, maybe we should test early. And we have a conversation with the family. The vast majority of parents say, no, we want our baby tested. If the baby is tested and has the mutation, that's really important information for all those things that we talked about, the startle, the avoiding QT prolonging medications. If their QTC is normal and they have the mutation, we may or may not start a beta blocker, depending on the family. I lean towards not, but if the family's super anxious, we could talk about it. And wait till they develop disease. And so, I think in this situation, we always try to offer it early, because those lifestyle modifications, the ability to treat severe disease, all kind of happens early in life. And we would be able to facilitate that with cascade screening.
Okay, excellent. All right, I think that completes our questions. If there's any others, please feel free to unmute yourself. Oh, here's a couple more coming in. Let's see. Catherine, clarifying, increased estrogen equal decreased potassium equals further delay of QT equals possible increased symptoms. Comments?
So I would view it as, if the salts in your blood are different, if there's estrogen that blocks the potassium channel, if there are medications, it's it changes that potassium flow inside the cell that's needed. And it may be a little bit, it may be a lot. So that's why you really can't predict what the effect of, say, estrogen and dehydration, these things are going to be, except to say that they could potentially slow things down. And so I think of it more as risk along the continuum. If you're very dehydrated, that risk might be worse. For some individuals, estrogen seems to block more, and you get more prolongation during puberty than other individuals. And so I don't think it's necessarily as linear, but maybe just a spectrum of risk that builds.
Okay, thank you. Let's see, Rob comments, we have been aware of swimming restrictions, especially competitive swimming. Are you aware of any peer-reviewed updates on swimming recommendations?
Well, there are a number of updates in general about guidelines for sports participation, particularly in kids. The most comprehensive one is 2015, American Heart Association. There are some that are more disease specific. If I'm not aware of anything that's specifically just for swimming, although I will say, for example, some KC and Q1 individual swimming is a particular carve out because of the risk there.
Okay, thank you. Bonnie has commented, fantastic session. Many thanks. Jeff, really helpful. Thank you very much for holding the session. Carl has a question regarding the beta blocker in pregnancy question. Labetalol is the classic go-to, maybe safest beta blocker in PG. Is it ever used for long QTS?
I typically do not use labetalol in long QT syndrome.
Okay. Is there a home test strip for potassium evaluation from Valerie?
Oh, wow. No, but if you could make one, that would be a great way to kind of reach financial stability later in life. You'd probably make a ton of money. There is not, unfortunately.
Yeah. Anne comments that during pregnancy, she was put on metoprolol for both of her children. Carla says, thank you very much. Very informative and clear.
My pleasure.
Yes. Any other comments, questions? We appreciate your feedback. We thank you for participating, and thank you, Andrew, for a wonderful session today. Rob says, oral potassium supplements.
I have mixed feelings about those. Typically, I think if the potassium is so low, it puts you at risk. I'd much rather have you getting hydrated or potentially in the hospital if it's that low. Oral potassium, first off, tastes terrible. If I think the gain that you get from it is relatively small. If you're really hypokalemic with low potassium because of a secondary illness, then probably something more is needed.
Okay. Well, thank you all for joining us today. We really appreciate your time, and we thank Dr. Landstrom for his time and expertise today. So thank you all. Enjoy the rest of your Saturday.
Thank you.